you have from multiparity. So these were from the Carolina breast cancer study 10 years ago. Bob published that if you had 1 to 2 live births and you never breastfed, you had an 80% increase relative risk compared to those that were nulliparous, and similar increase too for those who had multiparity 3 or more. About 7 years later, then we looked at this and published this within the Breast Cancer Family Registry, and these are just ER negative, PR negative cases, but again, seeing the very similar thing that Bob had shown, where you have this increase from parity, but then if you breastfed, that went away. And we also saw this in every race and ethnic subgroup that we have within the registry. So again, pointing to the fact that what Bob found, which is a very important public health finding, which is about breastfeeding for subtype ER negative, which really has no other, prevention. It doesn't have, I shouldn't say no other, it doesn't have the same kind of prevention options and treatment options that hormone receptor positive cancer does. So really important finding, but very, but also very generalizable to high-risk populations generally. So just as a summary then about this kind of first part, the design aspects, is cohorts that are not enriched for underlying susceptibility. They have to be larger at baseline. They require longer follow-up. And I would argue that you don't have enough precision to look at this spread of absolute risk, which really family history has a very wide spread. Okay. So in the second part then, I just wanted to highlight some analytic approaches to think about measuring the tail. So first I'm going to just talk very generally and briefly about kind of how we look for these interactions then. So this is just a typical pedigree. And so based on this, what we do is we estimate for each individual her absolute risk of lifetime breast cancer. We also do it at fixed intervals, and then depending on the question, we'll either do a 10-year risk or a lifetime risk. But here's just an illustration then of an average risk cohort. Again, it's going to have great precision for this lower risk distribution, and the dotted distribution is just meant to illustrate then what enrichment does when you enrich for the tail. And so when we look at this Bodicea score, obviously it helps predict the first cancers in the unaffected cohort. So now going forward, our prophecy cohort, which includes breast cancer family registry and this second site in Australia, the K-Confab, our unaffected cohort is about 18,000. Our affected cohort is about 12,000. So these were all women affected with breast cancer at baseline. But this family history measure, so now for the remaining slides, I'm actually going to just use a 10-year risk score because we only followed the cohort on average 10 years. So that's the reason for using this 10-year figure as opposed to lifetime. But you can see that obviously family history predicts breast cancer, your first breast cancer. But you can see that that twofold average really, it goes much higher depending on your risk score. And then the benefit of family history measurements is that it still has importance even after your first diagnosis. So these are, in the pink here, it's a smaller estimate, but it's still important for predicting second breast cancers within these families. So really what we look at mostly is just then this interaction. So basically we put together a set of environmental exposures. We put together, the Z here now would represent the absolute risk score, the 10-year risk score from a Bodicea-like model, and then we look for interactions. And so really what we're trying to estimate is whether or not this is different from 0, and if this is different from 0, then that's suggesting that whatever that exposure is has a bigger impact if you have greater underlying susceptibility. And if it's not different from 0, that's still a benefit to know, because if it's not different from 0, we have enough power to test that, and then if it's not different from 0, then the prevention message is that everyone benefits from this, right? And so just thinking about it, a priori, what you would expect to see is you'd expect to see this to be positive when you're looking at environmental exposures where DNA repair or some of these genes that put you at that tail. may operate. And you might expect things that don't operate that way to not have any kind of positive interaction. So here's just recency of pregnancy. So we were talking about recency of pregnancy because of Bob's finding. So this is just being within 5 years of your last full-term pregnancy. And you can see, again, all the slides will have this 10-year risk score. So in terms of National Comprehensive Cancer Guidelines, usually they say for a fixed interval, they say 1.67 for 5 years. So if we take a 10-year, again, because that's how long we follow the cohort on average, what we're talking about really is a cutoff right here of about 3.4. So everyone in this area here, I've highlighted it, if you can see in the back of the room, everyone in this area would be called kind of average risk, if you will. Okay, so they're under that cutoff. So, and you get like, you know, the, whatever, it's like 1.1, 1.2, whatever, in that range. So a modest increase. But again, that goes up as your underlying susceptibility goes up. So again, this is suggesting a very strong positive interaction with recency of pregnancy. Unlike when we looked at BMI, BMI did not have any interaction with family history. So the beta-3 was not different from 0. And so when we looked at how does BMI change with respect to breast cancer risk, again, this is all in the unaffected at baseline cohort. So there's about 1,000 prospective breast cancer cases. We see that basically the effect of BMI, as what's been seen in average risk cohorts, obviously is inversely associated and then goes positively. There's no magic, you know, cutoff at menopause, as we know, because that exists, you know, for a far too long period. Okay, so here we have just one example where recency of pregnancy did matter by underlying risk score. BMI did not matter by underlying risk score. So again, the benefit of having a tail, but what if what if our outcome itself was something we wanted to estimate? And what if we wanted to look at the distribution of Y and not just think about the tails of some of our covariates? And so again, the example that may be relevant here is BMI. So in particular, what we've done is some birth cohort studies and now some family-based studies trying to understand the impact of different exposures earlier in life on something like body mass index. And so what we could do, because the outcome itself is continuous, is do a least squared or linear regression. But again, all least squared regressions do is estimate the mean. And so in this is a hypothetical data set. And so if you were to just estimate the mean, you get basically a flat line, which doesn't really accurately summarize what's going on between X and Y. So, if someone were to ask you what's going on between X and Y, the more X you have, the greater the variance in Y, right? So one way is to do a quantile regression. So here what you see is the 50th percentile is the median, and that should, in a large data set, be close to a least squared regression method. But the higher quantiles all have a positive slope, and the lower quantiles all have a negative slope. Again, this is just an illustration to show maybe the benefit of using this kind of approach. And so we estimated this for a variety of different maternal and infant and childhood growth factors to really, one, investigate whether or not things like maternal pre-pregnancy body mass index or maternal weight gain had the same effect across the different quantiles. And here I just show you the 10th quantile, the median, the 90th. And you can see that both with maternal weight gain and maternal BMI, you do see different estimates. Here's the linear model, and here's the logistic. So again, if your overall question is just about whether these two things are associated, you still see the information here. It's just the quantile tells you really, well, it's only really seen at this higher quantile. So again, an argument for maybe looking beyond just the mean and looking more than just the average effects. So we also looked at this more recently now in siblings because we like to do family-based design, so we then took the birth cohort and then just created sibling sets within it. So mostly to kind of have a better match, if you will, for family SES. Still not perfect, but what you can see is that this effect of maternal pregnancy weight gain, which by the way has changed quite a bit over the past few decades, as much as I think it's 4 or 5 pounds in terms of the median weight gain, from about 23, I think, to about 28 or 29, but I haven't looked at recent statistics. But in any event, which is huge at a population level, but this having a higher maternal weight gain, pregnancy weight gain, only had an impact on the daughters in this 90th quantile, that it didn't exist across the continuum. So again, there's design methods that can sample the tail, there's analysis methods that can estimate the effects of different quantiles. So, so if we're interested in that, these methods certainly exist. So this is a paper my colleague in IBIS that has been working on, it's under review now, looking at varying coefficient quantile regression models. And here is just now thinking about, okay, if we care about those same factors like placental weight, birth weight, maternal body mass index, and weight gain, let's see how it affects the child. So all 4 of these panels are age and month. So this is about 5 years. How it affects the childhood body size and whether or not that differs by quantiles in childhood. And what you can see is the maternal BMI does have this departure very early, in the first 2 years. You can see the effect of the 90th percentile, and those things then kind of track over time. And then you can see the weight gain actually is this specific effect with the 90th percentile right about the time of adiposity rebound. So again, more information than if we were to just use estimates of the mean effects and things that we can follow up now to look about why pregnancy weight gain would have an impact more at the adiposity rebound part than earlier. And then we didn't really see any large differences in the placental weight effect or the birth weight effect. So then as a summary of part 2, really ensuring enough power for estimating the effects of exposure across this underlying spectrum is really then the benefit from an analytic point of view is that we can, very simply test that kind of interaction, but have enough power to test it across the underlying susceptibility. And then here, again, there's some benefits if we care about the y and the distribution of the y of estimating not just the average effect, but also estimating different quantiles. So then the last part, this is not so funny today since we just bombed Syria last night, but and if anyone knows the reference, well, the reference to the general statement is really then 20 years ago, or 10 years? 20 years ago, they made a movie, a political movie about Wag the Dog, when, I don't know if anyone saw it, but, but my examples here are really then to do twofold. So one is to think about how that tail can help us for risk assessment models. So specifically, can we use these high-risk cohorts to build a model that's relevant to anyone? Okay? And if we're going to say that, then we're going to have to at least have enough average risk people within our high-risk cohort to do that. And then secondly, how can we use these high-risk cohorts to inform questions about etiology? So first then, in terms of risk assessment, here are just 3 different commonly used clinical risk models. The Gale model, as all of you know, was developed in an average risk cohort. It contains information on family history, but just number of first-degree relatives. It does not contain, the website version, the one that people use in clinic, does not contain any information about BRCA1 or 2 mutations, and it does not include any polygenes. So breast cancer, like a number of other cancers, now have close to 100 different susceptibility variants. So models, that's what people know to be descriptive of the disease process itself. So a polygenic component of these models then would be useful because that's what we know to be sort of the reality of breast cancer. And then they do differ, these models, in terms of whether they include non-genetic risk factors. So yeah, nothing ever has everything you want, so there's trade-offs in everything. So for our our own cohort, we've compared these three models. And so the middle model actually has a lot of advantages, and this, incidentally, is being used, I think, pretty systematically now through Mayo Clinic for clinical reasons. You know, they've incorporated it, I think, into their you know, online medical record. So this has a lot of advantages, because if you know if they have a mutation, you can put it in. If you don't, the model estimates it based on the family history. It doesn't have the polygenes, but it does have almost every risk factor, or I think it has exactly every risk factor that the Gale model has. So these two are very comparable from a non-genetic point of view. And then Bodicea, like IBIS, has this multi-generational component, which, you know, for cancer, which is predominantly in women, is useful to know the father's family history. So the multi-generation beyond just the first degree is very relevant for breast cancer. But Bodicea, not yet, at least the online version, does not have non-genetic risk factors. They're extending it now, and hopefully in a few years it'll be validated, you know, to have the non-genetic risk factors. Places like Memorial use it for clinical care. Except for Memorial, I don't know of other clinics that use it in the US, but it's highly used throughout Europe and Australia. So this is a target. This is a woman in our breast cancer family registry. This is a New York woman within our, the breast cancer family registry. We have 6 sites in the breast cancer family registry, but this is a New Yorker. And so she's had 2 first-degree relatives who've had breast cancer. These are her risk factors. Okay? So if you ran all of this through Gale, it would say I have she has a 1 in 2 chance of getting breast cancer. These are not relative risks, these are absolute risks. That's pretty high, right? So that woman might choose, for example, to have, she's already 56, you know, she might choose, if she's just getting this information now, to certainly go on tamoxifen. She might choose to do a variety of different things. But what would IBIS show? So IBIS is the high, you know, the model using the pedigree. Do you think that would be bigger or smaller? Where's Ebony? Bigger? Bigger. Okay. Anybody want to say smaller? Nobody? You have a 1 in 2 chance. All right, it's actually smaller. And the reason is because she's already 56. So her mother and her sister were diagnosed very, very young. And so, you know, so the probability that she's a carrier is quite low, less than 1%. Okay? So, so here's just an example, just to show that using these models in high risk doesn't necessarily mean everyone's upgraded, right? Some people will have less risk, right? Some people will have more risk. But here, and even when you don't know their mutation status, these models estimate it based on the family history, okay? And even though these models are not very great or good at deciding who's going to go on to get cancer, they are really good at predicting a mutation, just like the colon cancer models. So most of the, well, certainly BRCA Pro, IBIS, Bodicea, they have a very high area under the curve for predicting if you have a mutation. So there's nothing preventing anyone from using these models. You don't have to have mutation data to use these models. You just need to know your family history. And even though years ago it was thought you can't get good family history data, actually now you can. Most younger generations, all of you, probably know your family history, or at least have living grandparents that many of our generation, we might have only had 1 out of 4 living grandparents that we knew, you know. So getting family history information and getting good quality family history information is no longer as challenging as it used to be. So, so here, this is just comparing for the New York site, the IBIS model and the Gale model. This is a diagonal, obviously. I'm tired, I'm sorry. This diagonal is what you want to see the point estimate to hit, because what it means is your observed risk. So this is following for the cohort about 10 years. This observed risk, if it matches what the model said, then these estimates should be spot on the diagonal. So here, these estimates are all higher, meaning we observed more cancers than the IBIS model predicted in these lower quantiles. But we were, you know, I mean, this is just the New York data. I'll show you more precise data with the larger cohort in a minute. But this one did not, the confidence limits are wide, but this was okay. So this was okay. So actually this model did better in the high quantiles, but underpredicted in the low quantiles. But look at Gale. Gale was actually much more of an underprediction in these low quantiles. So in the average risk women, Gale underpredicted worse than this underpredicted. And actually, interestingly, the very high risk, Gale kind of did better than this one, probably because in the very high risk, it's all about the number of first degree relatives. And Gale actually asked about first degree relatives. So, so now this is the larger cohort. The reason this is not 18,000 is because it's the messiness of families, and anyway, so so we do have really good pedigrees on about, well, 15,732 exactly. So these are really good pedigrees as opposed to the other pedigrees. We're trying to do some imputation methods for them now. And then in the under 50, we have almost 10,000 women here that are under 50. So of this 15,000, you know, 2/3 of them are under 50. So these are the expected to the observed ratios. So these two models, IBIS and Bodicea, are pretty much spot on. They include 1, which you want the numerator and the denominator to be close to 1, right? That you want the expected to match the observed. Gale really underperformed. And again, this was estimated and validated within an average risk cohort. So this is no surprise, but again,